Today in our lecture, you will listen about root canal obturation, instruments, features, filling materials, contemporary obturation techniques. The plan of our lecture will be to understand the viewpoints of root canal obturation, endodontic instruments for root canal filling, general requirements to endodontic obturation materials, classification of endodontic obturation materials, methods of root canal obturation, endodontic radiography, and the main aim of this manipulation, and the main possible complication after endodontic treatment. What I have to tell you about the purpose of root canal obturation. It is to produce a three-dimensional hermetic seal of root canal system with the aim of preventing infection or reinfection of the root canal by producing apical seal between the root canal and the apical tissues. It suggests that one of the goals of the root canal's filling is the entombment of the remaining bacteria and their toxins with the root canal system. Entombing the bacteria within the root canal system should result in all remaining bacteria being sealed by root canal filling indentinal tubules, lateral canals, apical ramifications, and isthmuses to prevent their communication with the periradicular tissue. Root fillings consisting of gutta-percha cones as a core material combined with root canal syrup have been standard practice for many years. However, variations in obturation materials includes the sealers, their classification you can see on your screen. What I have to tell you about the sealers, it's different types of these materials. The first type, a sealer cement paste resin only, a sealer and a single cone of a rigid or semi-rigid core material, a sealer coating combined with a coat compaction of core materials, a sealer coating combined with warm compaction of core materials, a sealer coating combined with carrier-based core materials. It is the main types of endodontic methods. What about the sealers? You can see the table. This table includes different types of sealers with component A and component B. H plus contains epoxy resin, calcium tungstate, zirconium oxide, and calcium hydroxide. And component B, for example, is endamantine amine, TCD diamine, calcium tungstate, zirconium oxide, aerosil, and other components. I think that you can see these components and contents of different types of sealers on your screen. And I can tell you about the newer materials. Newer materials focus on the deficiencies of the key groups of sealers and of gutta-percha. Whilst improvement placement techniques have provided time and cost saving, some improvements are aimed at replacing gutta-percha, often accompanied by newer sealers. Newer cores are produced from materials designed to match the size and tape of the canal preparation instrument, such that single cone obturation is now considered acceptable. Following its success in the treatment of the open episodes of hematotis, mineral trioxide aggregate may now be used as a root final material on its own in selected cases. In addition, MTA and related hydraulic calcium silicate cements have an increasing role as root canal sealers. Despite these developments, some root canal shapes, especially oval ones, remain challenging to fill. For the obturation exist the different types of endodontic instruments. It is a tool for filling the root canal with the sealers. It's a gutta condenser for condensation of gutta-percha points, mechanical condensation of gutta-percha points. And you can see the manual instrument for the lateral and vertical condensation of gutta-percha points. It is pluggers and spreaders. Root canal obturation aims to seal the pulp chamber and canal system from coronal micro leakage, prevent remaining microorganisms from proliferating, stop microorganisms entering the pulp space, though the apical foramen and other bedway lateral furcation canals opening into gingival sulcus exposed and open dentinal tubules around the tooth. Both equality canal obturation and well-sealing corneal restoration are critical to long-term success. Although canals can be filed immediately following preparation, in cases of infection, the use of intracanal medicaments reduces the microbial population and the presence of endotoxins and may provide an improved prognosis. Regardless, it's a requirement that canals be dried appropriately prior to obturation. The smell layer influences sealer adaptation, tubular penetration, and leakage. The greatest potential for leakage is the interface between the sealer and canal wall. Removal of the smear layer and irrigation protocols is discussed every time. Although the sealing ability and methods used to measure leakage are now considered outdated. They will be covered in this lecture as they have been employed for a number of years specifically in order to evaluate sealer performance and compare obturation methods. Root canal obturation materials and root canal obturation system. First of all, I want to show you the general requirements to endodontic obturation materials. It's an easy application into the canal, periapical and lateral canal obturation, no shrinking inside the canal, intensive to humidity, bactericidal or bacteriostatic effect, impenetrability to X-rays, no discoloration of the tooth structure, no irritation to the periapical tissues in the periodontal space, sterile or easily sterilizable, easily removable from the canal if endodontic revision becomes necessary. Sealers. Sealers play their critical role in sealing the root canal system by filling areas that are not occupied by the core filling material and though their endowment of remaining microorganisms after mechanical preparation. They also act lubricants and antimicrobial agents. A dense appearance of obturated canals on radiographs is desirable, but thumb weight Likely with all root fillings. Currently no sealer is available that completely prevents leakage. In general, conventional root canal sealers tend to shrink, can prevent the formation of an effect seal. All sealers are soluble to an extent, and all differ in their settings times, in their realize the leachate. The leaches can migrate through the dental tubules and the apical foramen, creating porosities within the materials. Most conventional root canal sealers do not possess any biological activity and have been found to be cytotoxic to the periapical tissues when freshly mixed, causing cellular degeneration and delayed wound healing. Sealer flow may be affected by root canal morphology. The core root filling materials, dentine tubules, and the smear line. Increasing the rate of sealer insertion may increase volumetric flow and reduce the viscosity of the sealer. However, with a reduced internal canal width, the reduced volumetric flow and increased was caused. In addition, increasing the rate of insertion does not necessarily improve sealer flow. This depends on the seal used and the width of the root canal. Similarly, reducing the powder-liquid ratio of a sealer may not improve flow, as it has been shown that flow may be reduced at a higher rate of insertion. Furthermore, the flow of root canal sealers is temperature and shear dependent and varies between sealers. No sealers is ideal, but many work well in clinical practice. Some are initially toxic and many may be absorbed to some degree after setting, though their volume is decreased. A lower solubility and the film thickness are requirements. Sealer penetrate in the dentinal tubules, which can be facilitated by methods such as ultrasonic obturation. This also improves the incidence of filled accessory channels. However, all sealers must be regarded as implantable materials, and so is necessary during the development of novel sealer types and delivery methods. While their characteristic differs, there is only limited evidence that different types of sealers influence treatment outcome. The choice is important when considering the obturation technique employed. Commonly used sealers can be divided into these groups based on their constituents: zinc oxide phenol sealers, calcium hydroxide sealers, glass ionomer sealers, resin sealers, silicon-based sealers, and HCSC sealers. Some words about these types of sealers or about these groups of sealers. Think of site sealers or ZOE. Sealers have a long history of use in endodontics and have commonly been considered the standard sealer for many decades. The original formulation took the form of a powder liquid with silver particles to provide radio opacity. Unfortunately, the presence of these particles caused this sealer to stay in the teeth. According to the manufacturer, is a non-irritating radio opaque seal. what about extend working time? The extend working time version here as the settings, setting time in excess of 6 hours compared to 20-40 minutes for the basic formulation. This was modified and introducing and non-staining zinc oxide eugenol sealer. This formulation is marked this sealer. The latter is a catalyst-based sealer, which means that it has faster setting time when compared to the earlier powder liquid versions. As a group, zinc ZOE sealers require water in their settings process are cytotoxic to the periapical tissue, shrink or statins are soluble and can stain to structure. Since gutta-percha soaked in eugenol showed an increase in volumetric expansion, the eugenol may exist in fresh mixes where it is not crystallized fully as zinc eugenolate. This combination of fruit-filling materials may counteract the shrinkage sustained by any sealer. Calcium hydroxide sealers. Calcium hydroxide sealers were initially developed to take advantage of the antimicrobial properties of calcium hydroxide, with the idea that they would display bioactive potential. However, they have not shown bioactivity. For example, Cl Apex, Apexit, and Apexit Plus are popular available version. Calcium hydroxide sealers have been reported to be both soluble and cytotoxic. The seal achieved is similar to that produced by zinc oxide eugenol sealers. For example, Dentalis is a calcium hydroxide sealer with uniform, which gained U.S. Food and Drug Administration approval. This material exhibits excellent radioopacity, but must be avoided in patients with an allergy to iodine. Glass ionomer sealers. Glass ionomer Siemens sealers were developed as restorative material. They offered the potential to bond to dentine by chemical bonding, suggesting a leak-free root filling might be achievable. Initial research of their endodontic tooth showed greater dye leakage compared to, for example, to AH26. The first glass ionomer cement sealer set to rapidly to allow the use of the lateral condensation filling technique. For endodontic application, radio pacifiers were required, and modification had to be made to the powder to increase its setting time. Prototype materials had similar leakage to valve funnel sealing. The main widespread examples for these sealers, it's a Ketak Ender was formulated in the 1980. The manufacturer's data of the time stated particle size from the less than 1 micrometer and to a maximum of 25 micrometer and a working time of 40 minutes. It was claimed that the adhesion to dentine would cause treated teeth to be straightened. Initial research reported the shape set leaving a working time of just 60 seconds. Considering the time needed to transport the sealer to the root canal system, This resulted in radiographically detectable voids in their resultant root film. For example, now I want to tell you about the example and different techniques of endodontic filling with these points, different types of points. A single cone gutta-percha technique is necessary with glass ionomer cement sealers in order to allow retreatment. This way, space can be created to re-instrument the canal following gutta-percha removal. Later, work investigated white bond, a resin-modified glass ionomer cement as a sealer. It was found the bond to gutta-percha was not better than with a zinc oxide eugenol sealer, but there was good adaptation to the root canal wall and it penetrated into dentinal tubules. White bond has a mean particle size of 25 micrometers and range from 8 to 40 micrometers. Its fluoride release may have a carriers inhibitory effect or demineralization inhibitory effect in the root canal walls, the entire root canal walls. The seal of the Kitak and the sealer was compared with age 26 and as showed a higher leakage, which was attributed to its first settings, high volumetric shrinkage, and it has failed during tetting. Support for the clinical use of Kitak end is derived from manatees treated by 3 operation. Bond strengths of glass ionomer cement sealers to root canal walls were investigated, and it was found that phosphoric and citric acid were preferable for smear layer removal. The ethylene tetracetic acid DTA when using Kitaken. Bonding without prior removal of the smear layer could not be measured. The bond strength of Kitaken and H plus to gutta-percha was better than to both structures. It was speculated that the glass ionomer cement would chelate with the components in the gutta-percha cones. This work draws attention to apical leakage and different interfaces. The disadvantages of glass ionomer cement as a sealer includes its poor antibacterial activity and the difficulties in present during retreatment. There is known as solvent. Glass ionomer cement exhibits some antimicrobial properties due to fluoride release, low pH values, wet settings, and the presence of gases such as strontium and zinc. An experimental glass ionomer cement-based root canal sealer was developed with an emphasis on enhancing antimicrobial properties. This consisted of a glass ionomer cement base combined with antimicrobial zeolites, porous ceramic structures that can enclose a core material, which may be either an alkali, earth, metal, iron, or an organic molecules. The promotion of the zeolite in the glass ionomer cement powder can vary dependent on the desired physical properties of the material and the antimicrobial dose required. Resin sealers. There are two main categories of resin sealers: epoxy resin sealers and metachloride resin sealers. Epoxy resin sealers have repeatedly demonstrated excellent physicochemical properties and are considered the gold standard in many experiments. H plus, for example, has been widely used for over 2 decades. It's a superseded the original H26, which became unpopular due to its release of formaldehyde, which reacted with the bismuth oxide in the preparation, leading to tooth and material discoloration. H plus contains zirconium oxide and calcium tungstate instead of bismuth oxide. It is less cytotoxic than H26, can be used in a thin film, has a lower solubility and releases only a minimal amount of formaldehyde. It is one of the most commonly used sealers as it forms a disadvantage in that it doesn't display any bioactivity or osteogenic potential. However, this means that it's more stable. An excellent review is available for understanding the better properties of this sealer. Complex canal system required considerable time to obturate and thus needs sealers with extended working time. Furthermore, if head is used during obturation, then sealer setting time will become even more extended. Metacrylate resin root canal sealers first appeared in the 1970s. As existing root canal filling materials didn't bond to root canal in time, metacrylate resin sealers was promoted as being adaptable and bondable, creating a monoblock system. Many generations of these sealers since been developed. Fourth generation, one is marked as Epiphany Real Seal. The manufacturer claims that it bonds to the resilon and attached to the edged root surface, resulting in a gap-free solid mass in the root canal. It has been concluded, however, that metacrylate resin seals do not create a monoblock root filling and hole to prevent leakage. An experimental resin sealer composed of 70% vinylidene fluoride, copolymer, methyl methacrylate, zirconia, and tributyl borate catalyst have been developed. Called androgen. Its dentine bonding and sealing ability were evaluated, and good engagement to both dentine and gutta-percha was demonstrated in comparison to controls. This fluoropolymer and substituted with polymethyl acrylate. The new material has been found to have good sealing ability, high adhesiveness to dentine, and easily removability. Silicone sealers is a polydimethylsiloxane-based sealer which expands slightly on deadens and is very radiopaque. The claimed advantages include good sealing ability, excellent biocompatibility, and very low cytotoxicity. Good flow is a modified version, contains particles of gutta-percha less than 30 micrometers in size. It expands similarly on curing and is considered almost insoluble. It is used with a single-masted gutta-percha cone without mechanical compaction, although lateral or vertical condensation is acceptable. It is flow into lateral grooves and depression in the apical region of root canals. Is significantly better than the lateral condensation or warm compaction of gutta-percha combined with H plus sealer. It is also effective in filling oval-shaped canals. Its sealing qualities are similar to obturation obtained by lateral compaction of the system B technique with H26. All traces of irrigants must be thoroughly removed by rinsing the canal with water or isopropyl alcohol prior to its introduction. Gutta-flow has working time of 15 minutes and setting time of about 30 minutes. Whilst Gutta-flow fast has a working time of 5 minutes and setting time of 10 minutes. A potential concern is extrusion of material beyond the apex, although its cytotoxicity is lower than that of some other sealers. Gutta-flow and Gutta-flow 2 consist of a small amount of gutta-percha in a capsulated form. The material is injected into a canal and then a single gutta-percha master cone is then placed. HCSC sealers feature a hydration setting reaction and have a hydraulic nature, representing a minor shift in the chemistry of the sealer types. They are mostly based on 3-calcium or decalcium silicate, and their main characteristic is the formation of calcium hydroxide when taken in contact with water. Unlike other sealer types, HCSC sealers interact with their clinical environment, leading their chemistry to change accordingly. This characteristic has been termed bioactivity. They don't conform to the ISO standard for sealer ideal properties, which was development for materials that are stable and whose chemistry does not change in use. Endodontic hydraulic sealers are hydrophilic settings by reaction with water. They are dimensionally sound, expand on tendons and have excellent properties for root canals sealing. However, their dimensional stability is dependent on their environment, as drying out will lead to shrinkage. The pH of unset hydraulic sealers is above 20. Due to the formation of calcium hydroxide and subsequent dissociation into calcium and hydroxyl ions. When mixed with water, a matrix of calcium silicate hydrides and calcium hydroxide is formed, which hardens with time. The calcium hydroxide then realized, which has been linked to bioactivity. It has been shown in vitro that it reacts with phosphate ions and physiologic fluid, resulting in the precipitation of hydroxyapatite. This is a similar interaction to that of bioactive glass. It is enhanced by the available of phosphates in the canal, such as with the final phosphate-rich irrigating solution. This has been shown for a number of sealers when it contacts with dentine. The hydroxide cooperate with the calcium silicate hydride, reinforcing the set materials. These properties improve the tissue attachment of bioactive conductive materials. HCSC sealers demonstrate radiopacity, which is enhanced with the radiopacifier, and they flow in the accordance with ISO with a minimum radiopacity equivalent to 3 millimeter of aluminium. Type 2 HCSC seals and CPM seals is based on NTA but have additives to improve its performance. This includes silicon dioxide, calcium carbonate, propylene glycol alginate, sodium citrate, and calcium chloride. It also contains bismuth. The material set within an hour, and the CPM sealer has been found to be dimensionally stable, but it exhibits significantly more leakage when compared with MTA fillers. The conventional calcium hydroxide-based sealer. It has been found to have a significantly higher Gauss stress to time compared to MTA, Philapex and H class. It displays antibacterial activity against Staphylococcus aureus and Streptococcus mutans when freshly mixed, although less than displayed by H+. It also displays biocompatibility. ProRoot and sealer and introduced in 2016, the main powder compounds are tricalcium silicate and decalcium silicate, with calcium sulfide includes andesitating retardant. Bismuth oxide is a radiopacifier and a small amount of tricalcium aluminide. They are the same components found in other sealers, but not being grouped by with the type 2 HCSC sealers. It is available as a pre-dosed powder and liquid and is designed for use with all obturation techniques. It can be indicated for use as a sealer in both cold and warm root canal peeling techniques with a working time of 65 minutes and a setting time of 20 hours. It demonstrated superior sealing to a conventional zinc oxide eugenol sealer and exhibits bioactivity when in contact with the physiological fluids. The type 3 of HCSC sealers demonstrate sound physical properties. It consists of a yellow colored base paste and white catalyzed paste. It is indicated for use in cold and warm root canal filling techniques. It has a high pH and therefore displays an antimicrobial activity. It was found to produce a greater zone of inhibition against entamoeba and in agar diffusion test when compared to the CPM sealer. However, neither sealer material was able sustain these antibacterial effects 7 days after mixed. MTA is more radiopac than bioroots. A tricalcium silicate root canal sealer, but less so than the conventional sealers such as N+. Type 4 and type 5 of HCSC sealers. The tricalcium silicate based sealers were developed to avoid the trace element contamination of Portland cement. The water base once includes bioroot, RCS, a powder liquid hydraulic tricalcium silicate based cement, which has been on the market since early 2015. This type 4 HCSC is recommended for single cone or cold lateral condensation techniques. Heating results in evaporation of the water component are reducing deadness times and flow and increase film thickness. The manufacturer claims it had a minimum working time of over 10 minutes and the maximum setting time of 4 hours. Although studies have found an actual final settings time to be 300 plus minus 5 minutes. The powder contains tricalcium silicate, povidone, and zirconium oxide, while the liquid component is an aqueous solution of calcium chloride and polycarboxylate. BioRoot RCS is formulated so it doesn't not stain teeth and has greater flammability and retreatment and simple to carry out. Obturation have shown the wide volume compared with H+. Although the materials in radio pack, this property is significantly less than that of conventional sealers such as A+ and pulp canal sealer. A recent in vitro study reported that BioRoot RCS was bioactive and biocompatible. Unfortunately, it has also exhibits some degree of cytotoxicity, although lower than that of conventional root canal sealers. It shows exceptional antimicrobial properties regardless of the irrigation protocol used. And the sequence BC sealer, also known as I-root CP. It is calcium silicate-based sealer, premixed ready-to-use injectable while high hydraulic cement base. The term bioceramic was coined for this sealer type. It is composed of tricalcium silicate, decalcium silicate, calcium phosphate, and in normal condition, it's set within 4 hours. If the dentin is very dry, it can take to 10 hours. It has radio opacity equivalent to 3.83 millimeters of aluminium, just above the minimum reference standard. Although one study reports the equivalent of 6.09 millimeters of aluminium. It has been found to accrete the force to fracture of root filling remover teeth, specifically developed two warm obturation techniques and the sequence BC seal, high flow, and total field BC sealer exhibit lower viscosity when heated and more radio opaque. Neither show any chemical changes when subjected to high temperatures with their non-aqueous radical preventing desiccation. Although I-root CP sealer has an initial antibacterial effects. There are the type, it exists sealers, this type of the sealers exist, the other type of sealers. Use of chloroform-based sealers such as rosin chloroform, Chloropercha has declined due to concern about their toxicity. Formaldehyde-containing sealers are no longer recommended because they contain substantial amounts of paraformaldehyde and are considered unsafe. Calcium phosphide-based sealers such as Capsil for example, are a variable. The presence of uniform and polyacrylic acid in this formulation is said to cause cytotoxicity, and questionable results have been found with regard to their biocompatibility. Almost all endodontic materials can discolor teeth, so it is unlikely and that many sealers will guarantee color stability in a root-filled tooth. This emphasizes the need to terminate the root fill well clear of the clinical crown, protected with an orifice barrier, and carefully clean the excess cavity before placement of the final coronal restoration. Except seal, the endodontic obturation techniques use core materials. It is the silver points, acrylic points, and gutta-percha. Due to silver points, due to imitations of early root canal preparation instrument, curved root canals were difficult to enlarge adequately to accept semi-rigid materials such as gutta-percha cones. Rigid core materials such as silver points first used in early 1941. Which could be forced down narrow canals, offered easy placement to the correct depths. Since placement was easy, the silver point techniques could sometimes lead to less care being taken during root canal preparation. Silver points could also corrode when exposed to tissue, fluid, or saliva, and their round cross-section led to obturation with the excessive silver. Being made of 99% silver, they were initially, though they offer valuable antimicrobial properties. But in fact, the corrosion products were toxic and could reach the periapical tissues and compound the problems caused by silver dissolution. Silver points are thus no longer recommended as a core root filling material. Acrylic points. Acrylic points are colored coat and radio pack. They are made of methyl methacrylate polymer, bismuth oxide, zinc oxide, and cadmium-free coloring agent. At the rigid core material, they are made to offer all of the advantages and none of the disadvantages of silver points, and they are promoted as being removable with both solvents or essential oils if retreatment is necessary. Gutta-percha, it's more widespread type of dental filling points, root canal filling points. Our 2000 plant species produce natural rubber latex. The main constituent of which is poly isoprene. The main constituent of endodontic gutta-percha, on the other hand, is 90 from 90 to 22%. Polytrans 1 for isoprene. Other constituents added to it for endodontic use includes zinc oxide, 49.75%, and ferrous waxes, coloring agents, actins, antioxidants, and metal salts as radiopacific. Their proportions vary to brand from brand, though there are considerable variations in stiffness, brightness, and tensile strength. To foliate feet, gutta-percha cones are available in different sizes and tapes. Gutta-percha has two crystalline forms. It's unheated B phase. The material is solid and compactable. When heated, it changes to the alpha phase, becoming more pliable, and capable of being made to flow under pressure. The alpha phase shrinks as the cools and sets, which is disadvantage clinically. The thermomechanical properties of gutta-percha have been well reported. Most of the changes in phase occurs from room temperature around 60. What about techniques? There are different techniques of endodontic obturation. Apical barrier. Creating an apical barrier when the apical foramen is open in immaturities of application, and it's important to prevent the extrusion of gutta-percha into the periradicular tissues. At 2 millimeter thick cone of MTA and another biocompatible material, such as, for example, biodentine, can be placed in immaturities at the apical barrier. Carrier breast section. A side filtered section of gutta-percha with sealer is inserted into the final 4 millimeter apical region of the root canal. The remaining root canal is filled with injectable thermoplasticized gutta-percha using an injection gun such as simply fill device. For example, I'll show you this device, this endodontic obturation system. The next carrier-based warm gutta-percha on a plastic carrier is delivered directly into the canal to fill it. Some of the main carrier system are dense fill, reseal, soft core, and Thermafil. You can see this system on the screen. It is a simple system for the root canal obturation, for the qualitative root canal obturation. When the condition of the root canals and of the teeth, it can tell us about that this teeth is not developed already. Chemoplasty advised. The gutta-percha is softened using solvents such as chloroform or eucalyptol, and is placed on already fitted gutta-percha points. The gutta-percha points are inserted into the canal, laterally condensed with spreader, and the remaining canal space is filled without ponings. The next quantity weight. A down-packing vertical compaction or core materials inserted in the apical region of the root canal using heating devices such as System B or element obturation unit, and then backfilling the remaining root canal with thermoplasticized core material using injection devices such as the Obtura elements obturation unit or hot shot heating devices. Custom core modeling. They are the surface, the outer surface of the gutta-percha points is softened using solvents such as chloroform or eucalyptol, and then it is inserted into the apical region of the canal to make a mold. Gutta-percha shrinkly hardens. So the points removed, sealer is placed into the canal, and then the points is reinserted in and condensed with the spreaders. Injection. Sealer is injection into the canal. Pretreated thermoplasticized injectable core materials is injected to obtura the root canal using a heating device such as obtura or ultrafil or Calamus system. Injection color. Sealer is injected into the canal. A cold flowable core material such as gutta-percha is injected to obture the root canal. Lateral compaction. A gutta-percha point with the same size as the final instrumentation size is cut to the working length of the root canal. The point is coated with the sealer and inserted into the canal. The points laterally condense with with spreader, and other points are aided to fill the remaining root canal. Thermoplasticized. A gutta-percha points coated with the sealer in place in the root canal. The point then rotated with an instrument to warm the core materials with function, with friction. The warm core materials it then compacted into the root canal. Vertical condensation. A gutta-percha point with the same size that the final instrumentation size is cut to a length of 4 millimeters. The point is coated with the sealer, heated and inserted in the apical region of the canal. The point vertically compacted with pluggers and warm gutta-percha points are added fill B remaining root to fill the remaining the root canal, and the warm lateral condensation includes the gutta-percha point with the same size. The final instrumentation size is cut to the working length of the root canal. The point is coated with the sealer and inserted into the canal. The point is laterally condensed with a warm spread, and warm gutta-percha are added to fill the remaining canal. But please put your attention to the screen. It is the most simple that it is the materials and devices for the most simple and qualitative obturation techniques. And the next part of our lecture, it will be description of the gutta-percha points and its advantages. Gutta-percha has many advantages as being inert, dimensional, stable after treatment, non-allergic, antibacterial, non-staining to dentine, radiopaque, compactable, subtable by head, subtable by organic solvents, and easily removable from the canal when necessary. It also has some disadvantages, being non-rigid, non-adherent to dentine, and capable of being extracted. Quad cones. To enhance the bonding of glass ionomer cement sealer to gutta-percha, one product consists of gutta-percha coated with 2 micrometers of glass ionomer cement particles on its surface. This was compared with H+ and gutta-percha in a bacterial leakage model, and no significant difference was found. Bioceramic coated impregnated gutta-percha cones are also available. The gutta-percha is impregnated with a coated and coated with calcium silicate nanoparticles and used as a single cone. When combined with the total fill BC sealer, no difference was found in fracture load compared with the teeth filled with the gutta-percha and H plus. The bioceramic combination, however, demonstrated high bond straight and greater sealer penetration at all root levels. Chlorhexidine impregnated gutta-percha points. It is the next type or next variant of gutta-percha points. Some studies have shown that entamoeba is relatively resistant to calcium hydroxide. In order to take advantage of the antimicrobial properties of chlorhexidine, especially to entamoeba and chlorhexidine impregnated gutta-percha points. Active points has been marketed. According to their manufacturer, it contains a gutta-percha matrix embedded with 5% chlorhexidine diacetate. Studies have been undertaken to investigate the antimicrobial activity of active points, concluding that they don't possess an inhibitory activity strong enough they completely eliminate a moderate large number of entamoeba microorganisms from infected human dentinal tubules. And in vitro study testing the cellular toxicity of medicated and non-medicated gutta-percha point found that chlorhexidine impregnated gutta-percha points were more cytotoxic and either calcium hydroxide impregnated or non-medicated gutta-percha points. Gutta-percha points impregnated with metronidazole. According to the abstract of study conducted on the China University, controlled trialized delivery gutta-percha points containing metronidazole compounds were made and placed in prepared extracted teeth. And on drug CDGMC was used in the control. The absorbency of the drugs is in normal saline pH 7.4 was determined, and the percentage of release, accumulated release of the drugs were calculated according to the concentration in medium. It was concluded that CDGMS could continuously raise effective drug concentration for more than 10 days. The introduction of antimicrobials into gutta-percha points and their disinfection prior to clinical use has recently been reviewed. Gutta-percha allergy. Causes of allergy to gutta-percha arise, but are unusual. There has been speculation regarding potential cross-reactivity between NRL and gutta-percha allergens in latex allergic patients, as they are related materials from the same family or trees. It was reported the lip and gingival swelling, throbbing sensation, diffuse urticaria, and tachycardia have been noticed following the placement of gutta-percha wound fillings. These symptoms resolved completely after removal of the fillings. In contrast, investigation of cross-reactivity between different latex materials using the radioallergic test inhibition assay concluded that there was an absence of cross-reactivity between whole or manufactured gutta-percha and NRL antibodies. Despite many techniques, has been used for three-dimensional operation of the root canal. Called lateral condensation of gutta-percha is still the most widely accepted. One main advantages of this technique is the ability to control the length of fill, simple and reliable that can be applied to most cases. However, this process is time consuming that has the potential to place a lateral force on canal walls, leads to vertical root fractures. Temporary filling materials. For treatment of the periapical zone of periodontium, the endodontists can use temporary filling materials. What about these? What about of its properties and determination of the term? An absolute requirement of material for temporary closure of an excess cavity is that it provides a bacterial tight seal. In other words, the material must prevent oral bacteria from reaching the unfilled root canal. Most widely used of the purpose is a paste of thin oxide as eugenol. Such as paste gives a good seal and has an antibacterial effect, which adds to its protective properties. The thickness of the temporary filling is another factor which contributes to its sealing ability. And the thin oxide eugenol type temporary filling filling should be at least 3-4 millimeters, and if at all possible, 5 millimeters thick. The root canal will then be well protected for several weeks. If longer periods of protection are required, reinforced zinc oxide eugenol materials like IRM cement may be used. Eugenol is a substance that inhibits the polymerization reaction of resin and can be therefore interfere with the bonding on a final composite resin restoration in the excess cavity. However, if the right precautions are taken, the influence of eugenol on the cavity walls can effectively be eliminated. The dentine should be cleaned mechanically with small burrs and then washed with alcohol. A normal acid and rinse technique may then be used, resulting in a resin-dentine bond as strong and reliable as the eugenol temporary cement had not been used. A temporary filling materials which is based on the zinc oxide and calcium sulfide, is another alternative. These materials is available in tubes and jars ready mixed to be inserted in the excess cavity. The material will set under the influence of moisture liver, and it gives a reliable bacterial tight seal with unset in the necessary thickness, 3-5 millimeters. The success of endodontic treatment is dependent on the obturation of the root canal with gutta-percha sealers, which can seal the entire root canal. There will be prevented micro leakage and the reinfection on the root canal. Over time, sealers and gutta-percha have become the standard approach to obturating root canals. Sealers are needed to seal the gutta-percha core materials and prevent micro leakage. In the absence of sealer, gutta-percha cannot adequately seal root canals and prevent micro-leakage and reinfection. Gutta-percha is most commonly used to obturate the root canal because it can be placed relatively easily and also be removed relatively easily in the tooth. Requires retreatment. The quality of root canal obturation can be seen in radiographs. A poor quality of obturation can increase the risk of flare up and retreatment. And retreatment. What is it? X-ray investigation and complication after endodontic treatment. Image A and image B. Image A shows the facial projection of the premolar, gives some limited information about pulp root morphology. Fast break, small arrow usually indicates canal bifurcation. A double root prominence of the mesial surface, large arrow indicates two bulges and then concavity. Its absence on the distal surface indicate a flat of convex root surface. And image B, the same premolar from the potential view. The presence of two dentine canals, each in its own root bulge, is confirmed. A different projection, different view of the shape and the quantity on the root channels. It may be diagnostic methods for understanding the quantity of the root canals in different teeth. Evaluating obturation. Post-operative radiographs provide considerable information on canal preparation and obturation. The lens from the apex to from the coronal part of the root canals to the apex or working lens. Post-operative radiography is necessary manipulation, and this provides considerable information on canal preparation and obturation. The lens from the apex density, taper, preservation of original canal shape, and general equality of obturation in each canal are determined from these radiographs. Please put your attention on the screen. Example, the next slide shows the example of clinical case before and after endodontic retreatment. It is the coronal part of the tooth. You can see the root canals. It is a lower molar, the first lower molar. You can see the radiographs, and you can understand that these teeth, these tooth needs their retreatment. The next image, the same teeth after retreatment and after filling with sealer and gutta-percha points. The radiographs in different projections shows us that the retreatment was successful, was provided successfully. It is the aim of retreatment and the aim of endodontic filling or endodontic obturation. You can see the homogeneous filling of each root canals. The lower first molars are often include 4 root canals, 2 mesial, 2 canals in the mesial root and 2 canals in the distal root. Please put your attention on the another slide and you can see here the results after endodontic obturation. It is the visual signs of qualitative root canal obturation. It's 0.5 millimeters after apex. It is 1.5 millimeters after apex, and it is 3 millimeters after apex. You can see homogeneous and hermetic obturation. In an effort to improve the quality of obturation of the canals and the development one vertical compaction of gutta-percha by using a headed spreader and pluggers or headed obturators to obtain a greater density of root canal obturation materials. Although more homogeneous filling was produced, voids were still present between increments of thermoplasticized gutta-percha. Gutta-percha cones are now produced to match the taper of canal prepare with the 0.04 or 0.06 rotary instrument. A large tapered gutta-percha cone can be used with one vertical compaction or with called lateral. The match taper single cone techniques has been used for obturation of curved canals. Single cone techniques performed with conventional sealers has been perceived to be less effective in sealing root canal than one gutta-percha vertical compaction techniques. Different authors describe the use of endotech thermal endodontic condensation. In a warm lateral obturation methods that combines the apical control of cold lateral condensation and the homogeneity of warm vertical condensation. And they also when comparison and the homogeneity of warm vertical comparison, the leakage of 4 filling techniques found the endotech's warm lateral produced significantly less leakage then lateral condensation. The head can be carried to the gutta-percha in the canal by a variety of ways, includes flame or electrically heated carriers like this can be head source. This device has the advantages of accurate temperature control as well as different diameter plug tips to accommodate a variety of canals wide. And what about control radiograph? What about the necessity? Some words about the necessity of the control radiograph after obturation and importance of radiography in endodontics. Radiographs perform essential functions of in 3 areas: diagnosis, treatment, and postoperative evaluation or follow-up. Each of these has elimination as that require its own special approach. A single radiograph is but a two-dimensional shadow or a three-dimensional object. For maximum information, the third dimension must be visualized and interpreted. The advent of 3D radiograph techniques such as CBCT, discussed later, has highlighted this concept. Digital radiography, the use of digital radiography is becoming more common in density, although there are technical advantages over conventional approaches. The same limitation apply. Overall digital radiographs are equivalent to conventional radiographs with regard to diagnostic and treatment-related accuracy. These factors and other considerations are discussed. Diagnostic radiography involves only identifying the presence and nature of mitosis, but also determining root and pulp anatomy and characterizing characterized and differentiated other normal structures. Radiography let's to identify mitosis. Radiograph must be studied carefully by someone with a working knowledge of the changes that indicate pulpal, periapical, periodontal, and other bony lesions. Many changes are obvious, but some are subtle. Determine the root canal and pulp anatomy. Determine the root involves has not only identifying and counting the roots and canals, but also identifying unusual tooth anatomy such as dense invaginatus and C-shaped configuration, and determined curvatures, canal relationships, and canal location. Identification also includes characterizing the cross-sectional anatomy of individual roots and canals. And post-operative radiography led us to understand the quality of the root canal obturation and perspectives of their positive effects and absence on the side effects too. Endodontic treatments tend to have very high successful rates in spite of the fact that they are quite an invasive difficult procedure, especially in complex anatomy. Some complications can arise during or after a root canal procedure due to poor understanding of the anatomy and iatrogenic errors, mainly during instrumentation. While some of these problems can be anticipated, many can never really be predicted. As a consequence, retreatment has become a needed of knowledge and expertise in endodontics, since most complications can be solved with the proper surgical or non-surgical retreatments. Reinfection or persistent infection. Root canal treatment can fall due to persistent bacterial infections or reinfections. These include inadequate shaping, cleaning, and obturation procedures, poor restoration, and exposure though a fracture. The remedies are dependent on the primary cause of the reinfection and the affected parts. Persistent infection is the main cause of short-term endodontic failures. The next complication is a missed root canal. Canal anatomy can be complex and variable. Clinicians can sometimes meet the canal in a complex tooth structure. The increasing use of more advanced 3D radiographic images, CB, CT, is very helpful to reduce these errors. The next complication is fractured root or crown. The carious lesions and the endodontic procedure, excess cavity and canal enlargement, leaves make it brittle and fragile. The fractures on the grounds of a root can be detected before, during, or after the root canal treatment. Crown fracture is the main cause of long-term endodontic failures. The next complication, depending on the extent and severity of the fracture, the dentist will advise or on whether instruction or fulfilling or choosing the correct option. Fractured instruments. This happens especially if the canals is complex are significantly curved and instrumentation stress become greater than the mechanical resistance of the instruments. And when the clinicians don't use their neatly flex instruments, being a quite fragment complication in a common practice. Many studies have been published to understand the mechanism of these iatrogenic errors and instruments resistance. A fractured instrument is a potential factor of a failure when it negatively affects the correct shaping and cleaning procedure. Clinicians should be very carefully and in avoiding overstressing mainly the rotary titanium instruments of rated tapers. Post-operative pain and discomfort is the next complication, which can appeared after root canal treatment. These are common symptoms immediately after a root canal procedure, but should resolve within a few weeks. If a tooth stays or becomes symptomatic after months or even years, this is a sign of the treatment failure. Symptoms related to discomfort or pain on chewing, itching, and though force are generally an indication of radicular inflammation or infection. It must be remembered that bony healing takes time and that a tooth that feels forbidden may be en route to healing. This should be confirmed clinically and radiographically. A pain on release may indicate a cracked tooth. A bad taste may be indicate a drying abscess. Occasionally, patients report sensitivity to cold or heat. This is most likely related to an adjacent untreated tooth or missing root canals, but would be an indication of a missed vital canal in a treated tooth. Post-treatment. As dental procedures, complication may be occur after root canal treatment. However, the incidence of long-term post-operative complications appears to be lower than the alternative single-tooth implants and fixed dental prostheses. In conclusion, the patient history, clinical findings, and detailed radiographic examinations are fundamental metrics of root canal treatment, outcomes assessment, and data they provide should never be underestimated. Thank you for attention. The lecture is